Everybody. The title of my study was Artificial Intelligence in the Diagnosis of Corneal Ectasia. Uh, Keratoconus is a degenerative and progressive non-vascular corneal disease which leads to thinning of the central cornea, resulting in irregular astigmatism and decreased vision. Diagnostic challenges posed by the FFKC and early KC cases because these patients show no symptoms and there are no detectable signs seen on routine examination. And in the past few decades, with the emergence and popularity of corneal refractive surgeries, it has become even more important to diagnose these asymptomatic cases because operating on these cases would lead to iatrogenic ectasia. So corneal topographic maps comprise of meticulous amount of detail where subjective evaluation becomes a task. And there has been a common consensus that Pentacam, which uses the skymflux system, has turned out to be a novel diagnostic tool in diagnosing corneal ectasia. So several artificial intelligence technologies have attempted to interpret these topographic maps, and scientists have developed several machine learning models wherein large amount of data is analyzed very conveniently and feature selection is performed to identify both best performing model and a subset of most promising corneal parameters in detecting both preclinical and clinical KC with high accuracy. So we conducted a prospective cross-sectional comparative study wherein 75 eyes were studied, and the inclusion criteria was patients about 12 years of age with corrected visual acuity of less than or equal to 6/6, presenting with complaints of shadowing or ghosting of images, frequent squinting, squeezing of eyes to see, frequent change in spectacle cylindrical power and axis, presence of irregular cornea determined by scissoring reflex on retinoscopy, biomicroscopic signs of KC, history of KC in the other eye, medical history of atopy, and family history of keratoconus. The basic preliminary examination was conducted after asking the patients to discontinue contact lens, and corneal topography was performed using Pentacam HR. The thinnest PACI value and the BAD-D score, the version 3 of the BAD-D score, was computed on a spreadsheet. The corneas were finally divided into two groups. Group 1 comprised of 67 eyes with FFKC, which had a BAD-D score between 0 to 1.6, and Group 2 comprised of 8 eyes with KC of moderate form with a BAD-D score between 1.6 and 3. Briefly about the machine learning classifier, wherein 500 patients were recruited to develop the classifier, and 2, 4 and 6 mm circles were taken on the total corneal refractive power map, and 360 data points were acquired from the center to the periphery, and the maximum dioptric power at these circles was marked as K1, and similar point exactly opposite was marked as K2, and the difference between these two was computed. Similarly, the minimum K1 and K1 values were computed. A decision tree classifier was used for classification of the data, and 1.4 was found out to be the cutoff value for the K1 minus K2 value. During the initial phase, we trained the tree on 70% of the data and tested the tree on 30% of the data. And our second validation step was an independent step wherein 75 eyes of either clinically or topographically proven cases of corneal ectasia were tested. Coming to the results, based on the receiver operating curve, it can be seen that the maximum K1 minus K2 of 2 and 4 mm circles was shown to have the maximum significance, and area under the curve of the TCRP map also showed similar results. There was no single TCRP index which was completely diagnostic of corneal ectasia, as the algorithm in a stepwise manner analyzed the maximum K1 minus K2 followed by minimum K1 minus K2 in the 4 and 2 mm circles, and any value which was greater than or equal to 1.4 was taken, and the analysis was stopped at this cutoff point. Coming to the discussion, several studies in the past have been conducted wherein anterior and posterior corneal curvature along with the corneal thickness has been taken into consideration to differentiate between keratoconus and early keratoconus cases. In our study, we have taken TCRP as the most reliable parameter in diagnosing corneal ectasia. Using the ray tracing technology, the incoming parallel rays are traced through the anterior and posterior corneal surfaces, and the measured focal length is converted into the corneal power. A wide variability in sensitivity and specificity of the K1 minus K2 value in diagnosing corneal ectasia was noticed in our study, and this could be due to the individual biochemical variation in each eye. Keeping this finding in view, the overall sensitivity of the classifier was 91% and it was 100% specific. The positive predictive value of the algorithm was 100% and the negative predictive value was 50%. Our algorithm was 92% accurate in diagnosing corneal ectasia. With this analysis, it can be said that our algorithm did not overdiagnose any of the tested eyes. The ectatic eyes were correctly classified as FFKC and KC eyes in accordance with their diagnosis based on the BAD-D score. When we analyzed our training set, the accuracy was 99%, but upon testing, the set accuracy reduced to 92%. The eyes tested were already diagnosed based on BAD-D score into FFKC and KC, and this could have been the confounding factor. There were 6 outlier cases in our study wherein...
Can you conclude, please? I think running short of time, you know.
So to conclude, we have described a machine learning classifier which considers topographic data, that is the TCRP, for the diagnosis of corneal ectasia, which is a derivative of corneal anterior elevation, posterior elevation, and corneal thickness, and it is not influenced by any of these parameters individually. It is advisable to explore the avenue for application of machine learning algorithms and neural networks in assisting identification of ectatic or susceptible corneas. This can aid in extending tertiary level cornea care at primary care centers.
So can we just give us the take-home message from the whole study?
So the thing is, Pantacam requires a lot of high level understanding of the maps. So what algorithm we have developed is, it just uses one value, that is 1.4. So any reading which is 1.4 or more can roughly tell that maybe this cornea is ectatic or into the preclinical ectasia case.
So this is basically for the primary center, you said.
Yes, sir.
So do you think a primary center will have a Schumfleck?
So that will not be, that we just need the data, so that's it.
No, but then you need the Schumfleck, no, for it?
Yes, sir.
So you think a primary care center will have a Schumfleck?